When's the right time to refer? Really, anytime. So, some of our MIGS-based procedures, are something that we can even do first line for patients. So I think that it doesn't always have to be a stepwise approach.
Our goal with glaucoma is to preserve the visual field for our patients over their lifetime. We don't want to wait until they've already lost vision before we intervene with more definitive treatment. There are a lot of patients that we can manage with laser or drops, but there are many patients that need more. Patients that are progressing, patients that are having trouble with side effects from their drops or having trouble with affording their eye drops, patients that aren't very good about coming in for all of their visits for their IOP checks. I think we need to understand who these patients are. I think we need to be more proactive in our clinics at identifying these patients. We understand what sort of challenges they may be having so that we can offer them additional options to manage their disease, MIGS being first and foremost in our practice.
There's really a variety of different situations that I think about. On one hand, you have the patient that has a visually significant cataract. They have glaucoma. To me, that's a no-brainer situation. The surgeon's going to do cataract surgery. They're going to be inside the eye. Let's do a MIGS procedure, make them see better, and control their glaucoma. But then you have the other side of the equation, and a patient that is pseudophakic. They've already had cataract surgery, but they're progressing, or they're having issues from their topical glaucoma medications. That's a patient where we can intervene with a standalone MIGS procedure and allow that patient to either have less medication or we can slow down their progression.
If we notice that the patient's progressing, even though we have them on therapy, even though we have them at that target pressure, but they're still getting worse, those are patients that we want to definitely refer, but we don't want to wait too long. And so if patients are having side effects from the medication, if they're having compliance issues, if there's cost issues involved, that's the right time to refer for patients for interventional glaucoma.
When we think about glaucoma, one of the words that comes to mind is control. IOP control is the disease control. But I think we have to look at who is controlling that disease. Is it our patient or is it us? I think we can do a much better job in potentially having better outcomes if we are the ones to help guide that process for the patient and not rely on them entirely to be the ones to treat their disease.
Find your surgeons in your area that do offer the MIGS procedures and learn more and communicate between each other, but also with the patient so you can give a consistent message to the patient on where MIGS fits into their glaucoma treatment. Glaucoma is lurking, and one thing that we don't want to do is we don't want to be too late to address our patient's condition.
The number of patients with glaucoma in the United States continues to increase, and this is going to double over the next 2 to 3 decades. We know that there is no cure, that this is a progressive disease, and this patient's going to need lifelong management. We also know that with MIGS, we have opportunities to intervene surgically at a much earlier time frame. Traditionally, we've waited until a patient has already lost vision before we start doing things that are more proactive. We've been very reactive in our approach. I think we need to, as optometrists, be proactive in educating our patients about the different options that are out there and understanding and being confident with making any recommendations for a MIGS procedure in our patients. Remember, glaucoma is there, it's lurking, it's progressive, but we've got new tools to help our patients have better outcomes.